Good morning, everybody. Thank you very much for having me today. So I'm going to go through my thesis with you on what's the impact of automated high-level disinfection on microbial colonization in ultrasound and endocavity probes. So as Pavan said, I work on the west coast of Ireland. I'm decontamination lead and SSD manager. My remit covers 1 Model 4 hospital and 4 Model 2 hospitals with a wide range of departments across all sites using ultrasound and endocavity probes. I completed my thesis using a systematic review. I wanted to research this area because I noticed that there was a shortfall in education in my group surrounding ultrasound and endocavity probes, and most were not using an automated system at all. Ultrasound is perceived as a safe and effective way of diagnosing and treating a wide range of medical conditions, but some users in our group, my group, and I presume everybody's group, are not aware of the importance of the correct decontamination processes and the harm that we can cause with ultrasound and endocavity probes if they're not disinfected correctly. So I completed my research in a systematic review, and our goal as clinicians is to provide our patients with the most up-to-date services while also protecting them from developing healthcare-associated infections. We need to increase the users' awareness of the link between microbial colonization and the use of endocavity and ultrasound probes. I use a systematic review method to do this, and I searched through CINEL, PubMed, Embase, Medline, and Google Scholar for my grey literature. And grey literature has arisen as a critical complement to commercially published research in systematic reviews. From there, I used the PICO method, which helped me clearly identify and frame my research question. And the search processes was conducted using specific keywords, databases, inclusion-exclusion criteria, and then my PRISMA. So I used a PRISMA framework 2020 then for each of my databases that I searched, and that led me to one overall PRISMA. So in total, I reviewed 289 articles, and using all those tools, it led me to find 11 articles that were suitable for inclusion into my research. My research actually leads it to a narrative synthesis rather than a meta-analysis. So using the PICO population for me in this was ultrasound and endocavity probes. The intervention was the use of automated high-level disinfection as opposed to manual wipes. And the outcome, my main outcome, was microbial colonization on ultrasound and endocavity probes. And possible second outcomes that I used would be incidences of healthcare-associated infections and education and training. Of the 11 articles that I researched, 10 articles had microbial colonization as their main focus. So from this slide here, we can see that Casilengo found that human DNA was detected on 36 post-examination samples and 28 pre-examination samples, and probe contamination with a high risk of HPV and DNA after low-level disinfection, despite the use of probe covers. Frazee noticed the prevalence of microbial colonization on ultrasound probes between patients. Ali discovered that 43% of probes had low-level disinfection or no disinfection at all, and 43% before use and 67% after use. Bouchier found that the automated disinfection system had a much higher success rate of 91.4 compared to 78.8 for the manual disinfection, and the risk of contamination was increased by 2.9-fold when people used manual disinfection. Sartoretti's article showed that the cultures from probes showed a mean of 53 CFUs before and 0 CFUs after training. Nigu was one that conducted a prospective study They separated the probes into two groups, those that had gluteral disinfection of the head only, and those that had automated disinfection of the head and handle. All the probes had been cleaned with detergent and water and dried after use, and 77 were processed using the glutaraldehyde method, and the 75 were used automation of the head and handle. The bacterial contamination obviously was higher on the probes from the glutaraldehyde group. Coombs noted that disinfectants that are used tend to have limited virucidal efficacy against HPV type 16 and 18, and both of these problems combined could result in the transmission of HPV. So these comments are from studies concerned with transmission of healthcare-associated infections to our patients and question the current low-level disinfection methods as opposed to using an automated high-level disinfection. And we can see here there, inefficient probe covers possibly causing an infection risk of contamination due to probe handles not being effectively disinfected, higher CFUs counted noted on ultrasound probes in comparison to public places, which I'll touch on later. Microbial colonization is not removed by wiping alone, and reclassification of ultrasound probes as semi-critical. The running theme is that we can actually, hang on there we are. So what does our research tell us? It's 80% of the probe handles were not disinfected and they had residual pathogens, including MRSA. It tells us that 18% of ultrasound probes were found to be contaminated with human DNA after incorrect disinfection. HPV and DNA are routinely detected on TB probes after incorrect or inadequate disinfection method used despite using a probe cover. And 13% of probe covers have tears pre and post ultrasound examinations. 43% of probes may have encountered sterile tissue, had only low-level disinfection or no disinfection at all. And bacterial contamination of ultrasound probes prior to disinfection training showed a higher bacterial load than toilets and bus poles, which I will come to. We can see from this slide the damage and risk involved through lack of education. Improved education for all staff is essential. When users are educated, the risk to our patients acquiring a healthcare-associated infection is reduced. Would any one of us like to have a probe like this used on us, but do we actually take any notice of the probe when we're having an ultrasound scan? I know I probably wouldn't have previously, but I do now. So what were the findings? The running theme is that ultrasound probes, if not cleaned and disinfected using automated high-level disinfection, can cause microbial colonization, thus increasing the risk of healthcare-associated infections, with HPV being the most prevalent, along with MRSA. There is need for an ultrasound and endocavity probes to be seen as potential vectors for contamination for our patients. Automated high-level disinfection is more effective at contaminating ultrasound probes, which improves our patient safety. Now, Sartoretti's article was the only study that collected swabs before and after training and compared them with samples from public spaces, which revealed that public spaces such as bus poles and toilet seats contain fewer bacteria than an ultrasound probe that had been not properly disinfected, which is quite scary. The efficient cleaning of ultrasound probes is only one facet of the total process. There may be other aspects to consider which these articles addressed, and they include sterile gel, correct disinfection of the probe head, high-level disinfection between each patient, standardizing the guidelines, and training for staff. So what did I learn from my research, and how will it help me going forward and help my patients? I started with the question, what is the impact of automated high-level disinfection on microbial colonization in ultrasound and endocavity probes. The findings suggest that while some departments and countries do follow automated high-level disinfection for ultrasound probes, there is also a wide range of other disinfection being performed or not. Ultrasound technology is more widely used in a larger number of hospital departments than we realise. All staff need to be more aware of the risk posed to our patients from routine ultrasound procedures. Disinfection of the ultrasound probe after each patient is essential. Standardisation, more user-friendly guidelines, and standard operating procedures for all staff is vital. More research is required into the use of sterile gel and probe covers. And when all of these factors are taken into consideration, it will help us reduce the transmission risk of healthcare-associated infections to our patients. This systematic review has shown that ultrasound and endocavity probes should be processed as a semi-critical device and be high-level disinfected using an automated system after every patient use. This is a validated and repeatable method of high-level disinfection, and this accompanied by education of all our staff, education, single-use gel, and suitable sheets and condoms will ensure our patient safety. Thank you.
Thank you, Ursula. So that's why, in line with guidance within Scotland, Ireland, and England, we can see that automated systems are considered best practice. Public Health Scotland published that there's a high-level published evidence to support the use of ultraviolet light systems for the decontamination of semi-critical ultrasound probes, but there's a low-level published evidence to support the automated chemical systems such as hydrogen peroxide, and there's low-level published evidence to support the use of a manual detergent-based system which could include different steps. So I'm from a company called Germitech, and we specialise in UVC high-level disinfection, and we actually won the award, the Prix Galien Award, for the best medical device. We specialise in two main product lines, which is the Chronos, which is for transvaginal and transrectal probes, and the Antigermix, which is for transesophageal probes and ENT nasoendoscopes. The Antigermix is the only UVC high-level disinfection system that's Class 2B in its classification. If any other product is classified as Class 2A, it can't be used as the end point of reprocessing. So for those of you that aren't aware, UVC disinfection uses UVC light. We all might have heard of UVA and UVB. That's what we apply our sun cream for. But UVC is actually absorbed by the atmosphere, so that's why we recreate it. And the reason for that is UVC uses a photolytic effect, whereby the radiation passes through the cell walls and damages the thymine bases within DNA. This stops it replicating and therefore destroys it, making it a very effective form of high-level disinfection, which viruses cannot become resistant to. So we harness this technology within our products with a special design that allows a proper illumination and efficient exposure to the medical device, which causes no shadowing. It's really important to us to ensure that our products are validated throughout the world, and we do that by performing carrier testing in laboratories and clinical in-use testing. At this point, I'd like to introduce Dr. Shannon Ali from UCLH, who will be able to talk to you about a study that we've performed in a laboratory.